Hi, good evening, everyone. Thank you for joining us. So, our topic for tonight is all about dry eye. So, I'm assuming that if you joined us tonight, you either have dry eye, you know someone who has dry eye, you're affected by it somehow, or you're just curious. And it is a very common disease. So, I thought we might start off with a little questionnaire so you can assess your own dry eye symptoms. So, I want you to grab a pen and just write down some of your own answers. So I want you to think about what has happened in the last 1 week. So not ever in your whole life, but what has happened in the last 1 week. Are your eyes sensitive to light? Do they feel gritty? Do they feel painful or sore? Sorry, it's on a timer. And do you have any blurred vision? Poor vision, and you grade that as all of the time, most of the time, half of the time, some of the time, or none of the time. So do you have any of these symptoms in the last 1 week and give it a score based on how often you've had those symptoms? And write down those numbers for me. Okay, next set of questions is, have you had problems with your eyes limiting you in performing any of the following during the last 1 week? So reading, driving, or specifically driving at night, working on a computer or bank machine. I would add to that, any kind of screen time using a tablet, your phone, or watching TV. And that is again graded on a scale of all the time, most of the time, half of the time, some of the time, or none of the time. And then the last set of questions is, have your eyes felt uncomfortable in any of the following situations in the last 1 week? Um, in windy conditions, places of dry humidity, I'm sorry, it keeps jumping to the next, or areas that are air conditioned all the time, most of the time, half the time, some of the time, or none of the time. So now that you have all of those scores, can you total the 3 pages, multiply by 25, and divide it by the total number of questions? So there are 12 questions. If you answered all 12, then that's 12. If you don't want to pull out a calculator, this is another way to do it. So the sum of all of your answers on the bottom and then go up on the left side based on how many number of questions you answered. If you answered all the questions, that would be 12. So make note of what number you got. It should be a number between 0 and 100, and keep a record of that number. We will come back to this number. Dry eye is very prevalent. It is a condition that is something we see all the time. All eye doctors see this condition, whether they are a dry eye specialist, a cornea specialist, a retina specialist, an optometrist. We all see this all the time. It's very common to have dry eye. And it's thrown around as a very catch-all phrase, but what really is dry eye? So this is the definition of dry eye put out by the Dry Eye Workshop, a group of dry eye experts. They got together and they published this definition that we now use for dry eye. And I'm going to read it to you. We're going to break it down also. Dry eye is a multifactorial disease of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiologic roles. Okay, so this is a lot to say, but I'm going to break it down for you piece by piece. So multifactorial means that dry eye is not just one entity. There are multiple contributing factors. It's not just one thing. Patients will ask me, did this happen because I'm now in menopause? Is this an aging thing? Is this because I use the computer too much? It's almost never one thing and one thing alone. Symptomatic means that this disease almost always causes the patient to feel something. Either they feel something or they see something, but they have some kind of symptoms. Occasionally, it will happen that we see on our exam signs of dry eye and the patient doesn't feel anything. That's more unusual. It can happen, but in general, patients tend to be quite symptomatic. And we will come back to that survey and that number that you just calculated. Loss of homeostasis is central to the definition of dry eye, and it means that the tear film is not acting the way it is supposed to be, and it is causing instability of the tear film and its function to protect the eye and the ocular surface. And so, if that tear film cannot act the way it's supposed to act, then you have a breakdown in the health and stability of the surface of the eye. The etiologic factors, they can be um, things that contribute to that tear film instability. It could be anatomic factors, it could be inflammatory, it could be biological factors, chemical factors, side effects from certain medications, consequences of other eye surgeries you have had, or changes of the eyelid that even if you make enough tears, it may not be functioning to spread those tears over the eye. So in order to explain this a little bit better, I'm just going to give you a quick anatomy lesson. So if we're looking at a cross section of the eye where this person is lying on their back and looking up towards the ceiling, we're going to focus in on the front of the eye. And then we're going to look at the cornea. The cornea is the clear covering in front of your eye. If you were to touch the surface of your eye, you would be touching the cornea. If you put contact lenses on, you are putting the contact lens right on your cornea. And in front of that cornea is the tear film. And that's what we're talking about today. So the tear film, it is not just water. A lot of people think that water and tears are the same thing, but actually tears are a complex
Yeah.
combination of multiple components. And it is not just there to keep the eye wet. It does other things, like it does serve as the initial layer that light hits. So it has something to do with your vision. It also provides oxygen to the cornea. It has antimicrobial, anti-inflammatory molecules in it to keep your eyes healthy, to wash away allergens. And if we break down that tear film, again, it's not just water. Yes, there is quite a lot of water, and we call that the uh, aqueous layer. The lipid layer sits in front of the water layer, and that is oil. So the oil is a very thin layer. It sits in front of the water, and the oil is there just to prevent evaporation of the next layer, which is the aqueous layer. That's the water layer. So the water layer is the largest layer, but is not the only layer. Finally, we have a thin layer of mucin. It's kind of like mucus that sits between the cornea and the tear film, and it holds on to the tears and keeps them from falling off the eye. The other anatomy lesson I need to show you is the structure of the eyelids are created so that when the two eyelids move and they meet, they are spreading the tears over the surface of the eye in this direction. So right now we're looking at the patient's left eye. The ear is to your right. And then on the left side of the image where it says the lacrimal sac, that's where the nose is. So the green colored glands are where the tears are being made, and they wash over the surface of the eye because the eyelids sweep that tear across the surface of the eye. So I say the eyelids are like the paintbrushes that paint the tears over the surface of the eye. You have to have both paint and paintbrushes to paint properly. And then the tears move towards the nose. In the corner of our eye, we have these small openings, and here you can see the openings lead to the canaliculi and then into the lacrimal sac. The lacrimal sac is here near the nose, and that's where the extra tears leave the eye. So the eye is making tears, the eyelids are sweeping the tears across the eye, and the extra tears leave down the nose. So if everything works great, you barely even think about your tears. But when the tears are not working well, then you get loss of homeostasis of the tear film. Things start breaking down. The ocular surface is not as healthy. So this is a cartoon to show you those different layers of the tear film and how they should be sitting on top of the cornea. So the tear film in this image is towards the top. Here are the cells of the cornea, and the tears are usually sitting right on top of the cornea protecting those cells. It should be that these cells of the cornea never touch the air. But in this diagram, you see these two excavations in the tear film. You're missing tears in certain areas, and that's going to cause a problem down the line. Not only for the health of the eye, but for the vision as well. So why is that? Because every part of the eye has something to do with vision. And so these light rays that are coming in from the left side of the screen, they need to go and come into sharp focus on the retina. But before the light hits the retina, it goes through multiple other structures. And the very first structure the light enters is the tears before it even enters the eye. So if you have an irregular tear film, the light hits that irregular layer of tears, and those light rays have already bounced in weird directions before they've even entered your eye, which is why a lot of patients with dry eye feel that their vision fluctuates and they describe it in different ways. Maybe they can read the 20/20 line on the chart and our technicians check, oh, how many letters can you read? And you can read down to the 20/20 line, but it's not a clear, crisp, sharp 20/20. Some patients will say it looks double. Some patients will say it looks ghosted. Some patients just feel like the vision is changing all day. And I'll ask, does it look different when you blink? If you close your eyes for a moment, open them again, do you see better? Does it seem more blurry at the end of the day after you've been sitting in front of the computer for hours and hours? Do you feel better on the weekend when you're not at work, when you're not staring at a screen all day? These kinds of symptoms mean that dry eye is affecting the vision. Okay, so how do we diagnose dry eye? So we diagnose based on a couple of different categories of things. First, before we even examine the patient, we talk to the patient and get an idea of their symptoms. Next, we examine the patient, look at the tears, look at the eye and how the dry eye is affecting different structures on the eye. And then we classify the type of dry eye this particular patient has based on our exam and other things that may be going on. So what goes into a dry eye evaluation? First, we talk about the symptoms, then we look at the eye and we look for damage that has incurred from dry eye. Dry eye symptoms can be varied. Patients may call it dryness. Some patients don't use that word. Some people say it's burning, it's scratchy. I feel like there's sand in my eye. I can't keep my eye open. My eyelids feel so heavy, or my eyes feel tired. These can all be signs, symptoms of dry eye. Okay, I'm going to have you recollect that number from the beginning where I asked you to write down the numbers and you multiply that by 25 and divide it by the number of questions you answered. And you should have gotten a number between 0 and 100. If your number is low, that's great. So if your number is less than 5, you probably don't have dry eye. The definition of dry eye, we think, should be usually around bare minimum of 6 on this scale of 0 to 100. Certainly, if you're above 33, this is severe dry eye. So this symptom scoring has been validated to be able to correlate with the severity of the disease. Moving on to the exam. How many of you have ever gone for an eye exam and the doctor puts in an orange colored dye on the surface of the eye? And it might either be with this bright orange eye drop, or they take out this strip, they put a little dot of fluid on the orange part of the strip, pull the eyelid down and touch the lower eyelid with that orange tip of that paper. This is a very, very common test done by the eye doctor. And this is a view of what we see. So the orange dye, when applied a tiny bit to the eye, it stains the tears, and we turn on this blue light, and anything that was stained with that orange will shine green. So that's why we use this blue light. It shows us the green color that was where the orange dye was applied. So in this situation, what we're looking for is the tear film. So do you see there's a green stripe right above the lower eyelid? And when the patient blinks, come on, blink. Um, you can see the tear spread over the eyelid, and you can also see that when the patient blinks, there will be more tear that you see at the top. There's another green stripe right up under the upper eyelid. Now, this patient's very normal, so you don't see much else, but I'll show you some images of patients who do have dry eye. So when we look at that green dye, we're looking for the tear film. So I can actually see how much tear the patient has sitting on their lower eyelid. So I can see if they have a lot, I can see if they have a little, and that's the stripe that I'm looking at. Now, the image on the right, you can see that there's sort of green in many areas, but then there's some areas of blue. So what we're looking for there is something called tear breakup, or specifically tear breakup time. So when the patient blinks, again, that's like your paintbrushes painting that green fluid over the surface of the cornea. But sometimes there will be areas where the green just disappears and the lack of green looks like those blue spots. So we ask the patient to blink. We ask the patient not to blink. They keep the eyelids open. And I start counting in silently in my brain, how many seconds have passed until I see that breakup of the tear. The normal tear breakup time is 10 seconds or greater. Another way to say that is the normal person should be blinking approximately once every 10 seconds. Now, if you blink once every 10 seconds and your tears don't break up or evaporate until 10 seconds or later, you won't have any problem. But let's say you blink every 10 seconds, but your tears break up at 3 seconds. That means for 7 seconds, there are areas on your eye that don't have intact tears. If this keeps going, and it's severe enough, you will develop what's called corneal staining. So again, we've applied that fluorescein dye, that orange dye. When we turn on the blue light, the orange turns green. Here, we're looking for these green dots on the surface of the cornea because those green dots stain or highlight the areas where the corneal cells are either absent, dead, or not healthy. And so when you have these little green dots, we call that staining. But another way to think of it is they are microscopic scratches on the surface of the cornea because the tears do not protect those cells from getting sloughed off. So it isn't that someone or something scratched the cornea, it's the dryness caused that scratch to happen because the tears didn't protect the corneal epithelium. So the two images I'm showing you here are very severe corneal staining. We can also do the same for the conjunctiva, which is the covering on the white part of the eye. In this particular example, we've used a different kind of dye. It's called lissamine green, and we just use the regular white light to see it. So anywhere that you see green dots, whether it's on the left here on the surface of the conjunctiva or on the image on the right, it's both on the conjunctiva and on the eyelid margin, that is also a sign of dry eye. Tear osmolarity, this has been shown to be a marker of dry eye, and what it means is that the tears are very concentrated. So the tears have solutes, salts, things like that in the tears. They, again, are not just pure water. So if you have high tear osmolarity, that means the tears are more concentrated in those salts or have less water content. So a value by the tear osmolality meter of greater or equal to 308 milliosmoles per liter means that you likely have dry eye. The other measurement you can do is to measure both eyes, and if there's a difference of greater than 8, that is also um, diagnostic. So not every eye doctor has this device, but it is a test that we can do if you have the device in the office. It just takes a tiny sample of the tear and it gives you a readout right away within like 10 minutes of what the tear osmolality is for that eye. So to sum that up, the basic diagnosis of dry eye, you have to have symptoms and you have to have some kind of exam findings that support that the tear film is not healthy. And further than that, there are other special tests. I wouldn't even call this one a special test, but we usually always look at the eyelids and the eyelashes because there are oil glands that are located in the eyelids. They're all along the eyelid, and along the eyelid margin, you can see the openings of those small glands. They're located near where the eyelashes come out. We also look at the eyelashes because some people have some dandruff-like material at the base of the eyelashes. So I'll show you that here. So on the left, this person has some clogged glands. And so you can see the openings of those glands look very prominent because the oil inside them is having a hard time coming out. We can also see these blood vessels that are called telangiectasias along the eyelid skin between where the eyelashes come out and the gland openings. That's a sign of inflammation of that area. The inflamed eyelid will have a hard time producing healthy meibomian secretions or oil secretions from those glands. And this image on the right, you can kind of see some crust at the base of those eyelashes. And again, that will cause some inflammation of that area. And because the eyelash is so close to the opening of the meibomian gland, these are related issues. Another test we might do to determine how much tears the person is making, it's called a Schirmer's test. So this test is helpful if we suspect that the patient is not making enough water portion of the tears, and that would signify the classification of aqueous deficient dry eye. So what we do is we put these little strips of filter paper and we hang them on the lower eyelid at the corner, have the patient close their eyes and sit there with the eyes closed for 5 minutes. After the 5 minutes is up, we take the strips out and you can see in this photo, this is me, and you can see these marks on the paper, and those marks there's 1 mark per millimeter. So when we take the strip out, we can see where the strip is wet, and then we record how many millimeters of wetness got onto the strip. So for a 5-minute test, normal should be at least 10 millimeters, which is around here. Some patients wet the whole strip and the entire thing is wet. Some patients with severe dry eye, it's like less than 2-3 millimeters. That's very, very severe. Here's another test that can be done to determine if there's inflammation in the tears. So this is a test where we take a small sample of tear by pulling the lower eyelid down, touching the surface of the lower eyelid just to absorb a tiny bit of tear. And then it's kind of like a pregnancy test or a COVID test, and you get the readout in 15 minutes. And so how you look at this, it really does look like a COVID or pregnancy test, doesn't it? So the blue line is the control, meaning if you don't see the blue line, then the test is invalid, it wasn't done correctly. And the red line means you are pregnant. Just kidding. It means that there is presence of an inflammatory molecule in your tears that should not be there. So a normal result would be a blue line and nothing next to the blue line. But in this example, there's the blue line is the control and the red line signifies that this eye has inflammation in it. There are other tests that we can do where we do some kind of fancy imaging of the eyelid, of the eye, of the cornea, of layers of the cornea to better look at the status of the dry eye. These are not always done, and a lot of them are done more for research purposes, but there are many other tests that I won't go into great detail about. So, what causes dry eye? There are many causes of dry eye, but I want to try to make it simple and just break it down into two main categories. So one is aqueous deficiency. So do you remember I showed you there are three layers of the tear film? The biggest one is the water layer. So if you are missing water, you don't have enough water, your eye isn't making enough water, that's called aqueous deficiency. Whereas if you are evaporating that water off the surface of the eye, that is called evaporative dry eye. And so in general, we categorize dry eye into one of these two types. And you can have both. That does exist. But in general, we try to think of these as two separate entities. And then within those, there are multiple different causes. And there are so many different causes of dry eye that can be as a result of something else. So there isn't a one size fits all treatment for dry eye because there isn't just one type of dry eye. One specific type, I'm going to talk about a few specific types. I don't have time to talk about every single type of dry eye, but I thought I might spend a minute or so talking about Sjogren's syndrome. This is a not super common cause of dry eye, but a very severe type of inflammatory dry eye, and it is a systemic condition. So usually the patients have dry eye and dry mouth. They may also have other autoimmune diseases, arthritis, or lupus, scleroderma. There could be other associated rheumatologic conditions, or you may have Sjogren's syndrome alone. If you have primary Sjogren's syndrome, it means you don't have other autoimmune disease, and the eye and the oral dryness does not have to be symmetric, meaning you can have very severe dry eye and mild dry mouth, or vice versa. But most commonly, you have both. LASIK, people ask about this a lot. We do think that LASIK makes dry eye worse, at least temporarily. And the theory behind this is that when LASIK is done, there's a flap that is made in the cornea and it is reflected like this. The laser is applied and then the flap is put back. And when the flap is made, you are cutting through the corneal nerves. They can grow back, but the corneal nerves are very important in maintaining that homeostasis because the cornea has a lot of sensation. When you feel dry, you really feel dry. And that dryness feeling feeds back to tell your body, to tell your tear glands, let me make more tears. So it can adjust. When you go to a more dry place, you may feel like your eyes water more. Or if you go outside and the wind is blowing, you may feel like, oh, I'm crying. It's because of this feedback loop. Your eye knows when it's dry, it will respond by making more tears. If we interrupt that sensation, it interrupts the feedback loop. And that's what we think makes dryness worse with LASIK. Usually, for most patients who have LASIK, we counsel them about this ahead of time. But if you have severe dry eye, you should think twice about doing LASIK, at least before you properly treat the dry eye. What is meibomian gland disease? This is the most common cause of the second category, which I called evaporative dry eye. So the meibomian glands, I will remind you, are those glands in the eyelid, and they produce the oil portion of the tears. And that oil, we want it to be like a really good quality extra virgin olive oil. But you can see that this oil coming out of some of these glands is pretty waxy. So my analogy for this is you want this extra virgin olive oil, but you have this cold butter. So you want something that's thin, smooth, pourable, easy to mix, and then you have this like really thick oil. So what does that affect? Well, to demonstrate this, I put 2 glasses of water And on the right, I poured some olive oil on top of the water. On the left, I put chunks of cold butter. And then see if you can read this recipe through these two glasses of water. So I'm trying to demonstrate to you why the patient who has this type of evaporative dry eye is going to feel like they have a hard time reading or it's affecting their vision. And we will come back to my analogy of the oil versus butter a little bit later when we talk about treatment. I also like to look for eyelid abnormalities. Like, for example, this person cannot close their eyes all the way. And remember, I told you those eyelids are integral to the function of the tear film because they serve as these paintbrushes that paint the tears over the eye. So if the paintbrush is only going here and only going here, even if you made enough tear, but you're missing this area, you're going to be dry. Here's a unique form of dry eye. We had a whole lecture about this in the past. And if you're interested, it's still on our YouTube channel. But if you are a person who has sleep apnea and you sleep with a CPAP that's like this, blowing air, and it's blowing air right up towards your eye all night long, and your eyelids are kind of loose, it's going to cause a lot of dry eye. And that's irrespective of your eye's ability to make tears. So I didn't go through every single type of dry eye. I just wanted to give you a flavor that there are many different reasons a person might have dry eye. And when we think about treatment, you have to also understand the treatment. There are so many different treatments. For example, here is our handout for dry eye. And I do not tell every patient to do every single thing on this paper. I customize the dry eye treatment based on what I think is wrong with the patient. So this on the left here, the address the underlying pathology. If the problem is the eyelids, then we address the eyelids. So, for example, if the eyelids can't close, I may send you to the eyelid surgeon to correct that. If it is a problem of evaporation, then we work on the oil glands. If it is a problem of the water producing gland isn't producing enough water, we try to increase that. So it all depends on what's the reason. But I would say the cornerstone of dry eye treatment is adding lubrication. Artificial lubrication, your eye has a problem either making the tears, keeping the tears there, or having enough volume of the tears. You can supplement with artificial tears, artificial lubricants that you buy. So here's a quick video of my daughter. So if you can think of my analogy, if you want to take a bath, but your bathtub is dry, you can buy water to pour into the bathtub. But depending on how dry you are, one application, or, in this case, 1 cup of water may not be enough. So it all depends. Some people might be able to use 1 drop a couple times a month, and another person might need to use 1 drop every 2 hours during the day. It all depends on your severity, and it's not about which drop is better or worse. So this is not a sponsored video. I do have some images of specific products. I just give this to you as examples, not to tell you which ones are good or bad. It's that there are many different over-the-counter artificial tears, and it's not which brand is better or worse. I think the brands are all good, but they vary in viscosity and presence or absence of preservatives. We always prefer preservative-free if possible. Now, if you're only using 1 drop in a blue moon, like 1 drop a week, it's fine to use the preservative-containing drops. But if you're going to be using multiple drops per day, we highly prefer the preservative-free versions. And all of the ones on the screen here are preservative-free. They also vary in viscosity, or like how thick the drop is. But there are downsides to this. If you use a very thick drop, it'll last longer on the surface of the eye. You'll get more relief for longer, but the thickness of the drop may blur the vision. If you use a thinner drop, it's more watery. It probably will not interfere with your vision, but it's going to dissipate quickly and you'll probably need to use it more frequently. At night, because you're sleeping and you don't need to read, then you can go with a very high viscosity product. So they make these specifically for nighttime use. I hate it when I hear that the patients are using the artificial tears at night and they say like it doesn't last all night. So they're waking up in the middle of the night to put eye drops in their eyes. For that, I would highly recommend you just switch to a nighttime gel or ointment. And again, these are over the counter, and I'm not putting these brands here to say that these are the only brands. I'm just giving you some examples. Patients often ask about lifestyle changes, and yes, you can make some changes to your diet, and there are over-the-counter supplements for dry eye. Be careful because now there are supplements for macular degeneration, for dry eye, and they are not the same. Contact lens use also is not good for patients with dryness, and environmental things like having a fan blow at your face, or when you're driving, having the air conditioning blow directly towards your face is not going to make the situation better. So if you can reduce the amount of air that is blowing directly at your face, whether that is from the heater or a fan, also if you are someone who does a lot of screen time, and it doesn't have to be a computer. It can be reading a book, a magazine, watching TV, using a tablet for a very, very long period of time. Remember, I told you that the tears are supposed to break up at 10 seconds or later. What if the normal person blinks every 10 seconds and their tears break up at 10 seconds? They will be fine. But if your tears break up at 3 seconds and you don't blink for 15 or 20 seconds because you're staring at a screen, that by itself is going to exacerbate your evaporative dry eye. So some things that you can do at home, we often talk about warm compresses, and it can be as simple as you take a clean washcloth, put it in hot water, not boiling water, hot or very warm water. You should be able to feel that it's hot, but not so hot that you can't touch it with your hands. And then you lay it on both eyes with the eyes closed for 5 to 10 minutes. And why do we do this? Because I showed you earlier, those meibomian glands are making oil. And that oil, we want it to be really smooth, thin, liquidy so that it comes out easily. But look at this. I'm squeezing with these Q-tips and I cannot get them to come out. By the way, you see this person has a lot of eye makeup that hasn't been properly removed, and some of that eye makeup is sitting right on the openings of those meibomian glands. And that oil that came out is not thin and watery, it is very thick. So when you do your warm compresses at home, you are trying to get this cold butter and melt it so that it's a little bit more like that olive oil, which it's still not going to be perfect because it's still quite thick and turbid, but at least warming it makes it softer, maybe easier for it to come out of the gland. Okay, I'm going to give you another analogy now. Like let's go back to our bathtub analogy. So those of you with small children like me, this is not unusual to come to the bathtub and it's full of children's toys, and that's not very comfortable if you're going to lay in the bathtub. So my analogy here is that if you have tears that are full of inflammation, you are bathing your eye in those inflamed tears. And we know that if you have chronic dry eye of any form, eventually that will develop into an inflamed situation. And then the tears are inflamed, they're sitting on the eye, it is making the eye inflamed, and it is a vicious cycle that never ends. So we like to treat that inflammation with anti-inflammatory medications. And there are several on the market that are safe to use long term. We might use steroid short term to quickly bring down the inflammation, but we don't like to use steroid, especially long term or in high doses. So we usually try to use one of these dry eye medications that does have anti-inflammatory effects to clean up that inflammation to make the tears healthier. A lot of patients misunderstand that they think they put this drop in the eye and they should immediately feel better. No, these medications are in it for the long haul. You're trying to get the tears to be healthier overall, not for you to feel better in that moment. For that, you want to use your artificial tears to add moisture. The purpose of these isn't necessarily per se to add moisture, although reducing that inflammation allows your body to create healthier and more tears. Okay, so let's go back to this analogy of the bathtub. So you turn on the faucet and you're expecting a lot of water to come out. But instead of that full stream of water, you turn the faucet on and you just get a little bit of drips. You will never be able to fill this bathtub with enough water if you produce this little amount of fluid. So how can we change that? So there are some medications that will tell your body to stimulate it and tell it to make more tears. And these medications are available in multiple different forms. So there's a new topical eye drop that tells your eye to make more tears by activating the nerves on the surface of the eye. There's a nasal spray that you spray in the nose. I know this sounds kind of funny, but if you think about it, this is sort of an analogy. It's not exactly how the drug works, but when you cut onions, there's this potent smell, and then you start tearing involuntarily. It's not an emotional response, and it is not necessarily because your eyes are dry. It's because the onion smell is activating a nerve receptor inside the nose, and then it triggers the eye to make more tears. So this medication is harnessing that connection between that nerve ending inside the nose and the eye's ability to make tears. It does not smell like onions, but it is a nasal spray that you spray in the nose. There are oral medications, pills that you can take to tell your eye to make more tears. We generally do not use this for the average patient with dry eye, but it is good for patients with Sjogren's syndrome because it also tells your mouth to make more saliva. So it is good for those patients, but we aren't using these oral medications for all patients with dry eye. Have you ever heard of tears that are made from your own blood? So it sounds scary, and patients immediately think that the drops are bright red. But as you can see here, they are not red. So what happens is your own blood is taken from your body and prepared into these eyedropper bottles. So the red blood cells, white blood cells, and it can be further purified to just have all the good stuff in the tear. And then we add some sterile saline so that it's not so thick. And then that gets returned to you in these bottles. You refrigerate them and you use this in lieu of your artificial tears. And the idea is that artificial tears you buy over the counter are basically just water, salts, maybe some emollients. And it doesn't mimic how the natural tears work because those have biological functions that we talked about before. So there are growth factors, there's anti-inflammatory factors in these tears that you're not getting by buying over-the-counter artificial tears. And so we can try to replace those by making more tears that come from your own blood and then bottling those. This is so far not covered by insurance, though, and you have to go through a special lab to draw the blood. There are some eye doctor offices that will make this in the office, or there are some places that we can send the blood and they will mail the drops back to you. If you have evaporative dry eye, either because you have very poor oil component to the tears, or maybe your eyelids don't close all the way, you've had cosmetic surgery and the eyelids can't close, or there's something wrong with the function of the eyelid and they just don't close when you sleep, then trapping the moisture in this area is very helpful. So it's almost like you're wearing swimming goggles, but the idea of swimming goggles, you keep the water out. Here, what you're trying to do is keep the humidity in. So you could wear these types of glasses. The one on the left is for daytime wear. It has a padding around the glasses so the air cannot enter. So you put your artificial tears on, you put the glasses on, and all of that moisture is locked in. Doesn't even matter if you're walking around in low humidity. You could be walking through the desert, and it will keep the moisture in here. The one on the right is for sleeping. So some patients don't close their eyes all the way when they sleep and they get really dry at night. This is the solution for those patients. How about lid scrubs? There's so many different products now on the market. We used to tell patients to use baby shampoo, and you could still do that. You could buy baby shampoo, dilute it with water, but there's so many easier ways now that there are these commercially available products. But why do we talk about lid scrubs? So I had shown you earlier that image of the eyelashes with the sort of dandruff-like material, and that causes inflammation of the eyelid. And because the glands that make the oils are so close to that area, it will affect the eye's ability to make healthy tears. So that's why we ask you to have good eyelid hygiene. The other reason is you can get these mites that live inside the lash root, and these are microscopic. Even I cannot see this little critter that's on the bottom right of my slide. I don't see that even with my microscope, but I can tell that they are there because of the certain way that dandruff-like material looks when I look at the base of the eyelash. And there are special wipes for this. There's also a medicated eye drop that can get rid of these mites. Now let's talk about some procedures that we can do in the office to treat for dry eye. So I had shown you before that there are some patients who have this clogged up oil in the eyelid. And I use the analogy of you have this clogged up butter when you want olive oil. So you can do the heat compresses at home and you can try to melt that butter, but sometimes you really just have to squeeze it out. And this is not something to do at home, folks. So you can come into the office and we will heat and express the glands and get all of that clogged oil out until the new oil is nice and clear. So sometimes we get like a lot coming out. So there are different machines that are used for this, but in general, they're all trying to accomplish the same thing. So there's another type that the machine heats and squeezes all at the same time. And so here is a cross-section diagram showing that the glands are being heated and it's squeezing out the clogged up oil. This is what it looks like in the office. This. So this machine is heating and expressing all at one time, and the patient is just keeping the eyes shut, and the machine is doing all the work. And it doesn't hurt. It's not squeezing particularly forcefully. It's more like a massage. And there are other devices that I haven't shown, but in general, they're all trying to do the same thing. Okay, so going back to my analogy of the bathtub. Before you take a bath, what's the first thing you do before turning on the faucet? And this is not a trick question. And believe it or not, I get all kinds of answers when I ask patients this question. Everything from, I get naked to I use the toilet first, all kinds of things. So I'm going to let you see what my son is going to say about it. Now that you push the drain, can the water fill up? Can we have water in the bathtub? Yeah. So then we can take a bath, right? So the point is that if you don't plug up the faucet drain and you just have a little tiny bit of water coming out of the faucet, but the drain is wide open, you will never accumulate enough water to take a bath. So bringing that back to the eye, what I mean is if the eye doesn't produce enough volume of tears, but you're letting all the tear that you make leave the eye, then one solution that we can use is to stop the tears from leaving the eye. So we all have this natural drainage duct, not to be confused with the tear-making glands. We have a tear drainage duct that exists in the inner corner, and it drains tears into the sac that's inside the nose. And from there, it drips into the back of the nose, into the back of the throat. You swallow those extra tears. Not that your nose or your throat needs that extra moisture. It's simply a way for the extra tears to exit the eye, just like the gutter takes the rainwater away from your house when it's raining. But if you live in a desert and it never rains, you really don't need a gutter, right? So in this analogy, what I'm saying is that if you don't produce enough tears, we don't really need the tears to leave the eye. So how can we fix that? Something called punctal occlusion or punctal plugs are one way to accomplish this. So what we are doing is we're putting in the hole that naturally exists for the tears to leave, we put a plug in there. And this purple one happens to be made of collagen. It will dissolve and it goes inside. So often patients will ask me like, "Oh, Dr. So-and-so put a plug for me. Can you see it?" And when I tell them I cannot see it, they get upset. But actually, the collagen plugs are not intended to be on the outside. They are all the way inside like that. So it's hard to see them once the procedure has already been done successfully. And they don't last forever, these collagen ones. They will eventually dissolve. So it's a nice way for you to sort of test drive the car before you buy it, because whether you love it or hate it, it will dissolve. And if you love it, but then it dissolves, then you can either do it again or you can switch to this kind, which is a plug made out of silicone. So the silicone plug goes in, and there's a little cap that you can see right there. And if you don't want it anymore, it is reversible. So it is made of a material that can stay forever. But if you don't like it, we can simply remove it by pulling it out of the eye. So it is reversible. And finally, I just quickly say that there is another modality that we can use for a temporary treatment where we put stem cells on the eye, and we get stem cells from this layer on the outside of the placenta that we call amniotic membrane. So the placenta is full of growth factors, and the lining of the placenta is removed. It is treated in such a way that the cells are not live anymore. In fact, this upper one, you can see it's dehydrated into a very, very thin, almost paper-like consistency. And that can be applied to the surface of the eye. And it doesn't stay there forever, usually just a few days, maybe a week, but that kind of like jump starts your dry eye to be treated with the stem cells. And it can be repeated, but this is not intended to be a treatment that you do every day for the rest of your life. We just kind of like do it at certain time points, especially when you're doing poorly. And some patients find they benefit from doing it repeated over months or like once a year or such. So in conclusion, to summarize, dry eye is a complex multifactorial disease. It causes discomfort, symptoms, and can interfere with vision. Dry eye is diagnosed based on your symptoms and exam of the eye, not only the eye, but the tear film, the eyelids. And there's so many different causes of dry eye, and the classification of dry eye is there are many. And the treatment should be personalized for each person based on the factors, anatomic or otherwise, that are specific to you. If you'd like to come see us, here are our two locations, and Dana can also give you this information as well. But you're welcome to come and visit us here.